Hello and welcome back to Conceptual OBG. Welcome back to yet another YouTube live session with me. And today I'm going to be talking about one such organ which I personally dread the most. It is one of those organs that I have genuinely dreaded, and I will attribute that more so to the fact that as an obstetrician or as a gynecologist, I haven't cared much, or the circumstances haven't favored me learning more about it. The ureter. Of course, ब्लैडर से डर लगता है साहब, लेकिन ज्यादा डर मुझे लगता है यूरेटर से. क्यों? बिकॉज ब्लैडर इज अ वेरी फॉरगिविंग ऑर्गन. The layer inside the bladder is your transitional epithelium. And this transitional epithelium is a beautiful epithelium. The reason I say that it's a beautiful epithelium is that it is forgiving. So the moment you injure it, within 5 minutes, they say it starts regenerating. And if you do a primary closure, a watertight suturing, a watertight repair is done, then there is no chance of it leaking or causing a fistula. So bladder is a forgiving organ, but what is not forgiving is a ureter. It is absolutely not forgiving, and it is in fact something that will make you think twice about your decision of becoming a gynecologist. So welcome, and today I'm here to exactly tell you what should be your approach towards all these ureteric injuries. Of course, I would recommend that you all, if you all do intend to learn it alongside a urologist or a urogynecologist before starting to do it yourself. You can repair the bladder on your own without the presence of a urologist or a surgeon, but do not go for repairing ureteric injuries because if it gets complicated, because it's a retroperitoneal or retroperitoneal organ, it is very difficult to, to get access to it and then to repair it on a secondary basis by the urologist. So welcome to this session, and if you all have any doubts, please let me know in the comment section. I'll be reading all these comments in the YouTube Live's comment section and I'll be answering them immediately. So, the first things first, अगर मैं ureter की बात करता हूँ, so when I talk about the ureter, I first need to know a few basic anatomical things. So it is around 25 to 30 centimeters, of which the first 12 to 15 are the abdominal ureter, and the next 12 to 15 are the pelvic ureter. Okay, so minor variations. Overall, it is, of course, 25 to 30. So half of it lies in the abdomen and half of it lies in the pelvis. When I talk about this, I of course first need to know not just the anatomy or the path along which it goes, but also the microanatomy when I take a cross section. So when I take a cross section, I've actually shown a picture here. It is taken from Teeland. So I've used Campbell, Urology, Teeland, and a bit of Berek and Novak to prepare uh, for this session. Campbell is the Bible of urology, so I've used that in bits as well for the surgical anatomy part. So now over here you are seeing that the ureter has three important, very important three parts when I take a cross section. So the outermost layer is the adventitia layer. The adventitia is like a coating that it has, and the good part about this is, or the important part about this adventitia is that you can see that in this adventitia there are blood vessels. So these blood vessels that are circumferentially flowing, they not just vertically go down circumferentially, but they also send in branches circumferentially. So basically, the horizontal and the vertical segment of the adventitia is covered or has all the vessels supplying the ureter in it. So basically, ureter is a highly vascular organ. After that, I have my central layer. The central layer happens to be the muscular layer. So this muscular layer, if you can see, I'm coloring it yellow. So this muscular layer is consisting of three different types of muscles. So the outermost is going to be the longitudinal, the central is going to be the circular, and the innermost is going to be spiral or spindle. I would rather prefer the word spiral. So these are the three layers, whereas the innermost layer is made up of the ureteral mucosa, whereas the innermost, more than that, this inside layer is also again made up of the transitional epithelium. Now, transitional epithelium is a rapidly replacing itself by epithelium which regenerates quite quickly. So these are the three main layers that you need to know of the ureter. If I look at the vertical section of it, you can see over here how each and every layer is supplied by these vessels. Now, why is it so important to know the vessels? Because the ureter is one such organ, because of its vertical length of 25 centimeters, one single vessel cannot supply it. So it takes the blood supply from various major vessels and supplies itself. But for that, I now need to know what is the exact pathway along which it flows. So the moment it arises from your renal pelvis, it goes downwards, and it goes downwards on a muscle called as psoas major. So over here you can see this is a psoas major muscle, both the sides. So this is the psoas major muscle over here. You can see over here as well. So it vertically comes down onto the psoas major. And apart from that, of course, if I have to see the psoas major, I have to go into the retroperitoneum. So it's a completely retroperitoneal organ. But apart from that, a few important relations here that you need to know are with the IVC and the aorta. So if you see that it is lateral to both of them, but occasionally it can be lying, the ureter that is there on the right side can be occasionally lying on the inferior vena cava, and need or care has to be taken that whenever you need to dissect the ureter, or what you call as ureterolysis, for lymph node dissection or for anything, then if it is lying on the IVC, you have to be extra careful. Regarding the left ureter, it is always going to be lateral to the abdominal aorta. When I say that, you see that this left ureter is also going to be present behind two important vessels. One of these important vessels I'll mark with a pen originates over here. So this over here and again this over here happens to be the ovarian artery, or what we also call in a generic way the gonadal artery. So in females, it is the ovarian artery that goes down and then comes in the infundibulopelvic ligament and supplies the ovaries on both the sides. And the second one is going to be the inferior mesenteric artery. So basically, it lies posterior to both of them, and it comes down, the ureter comes down in a similar pattern and enters the pelvis at the bifurcation of the common iliac. So this is the common iliac, CC, and then it bifurcates into two branches. The outer one happens to be the external iliac, and the internal one is, of course, the internal iliac. So it again keeps flowing lateral to it, and then it gradually comes medial to the internal iliac, and then when it comes down, it suddenly turns anterior and also comes medial. So you see it comes down like this and turns medial and anterior through something called as the tunnel of Vardheim. The same Vardheim of whom hysterectomy you have heard of. So it comes down into the pelvis. It comes at the pelvis, at the pelvic brim or the pelvic inlet. You have your bifurcation of common iliac. At that point of time, it still continues going down. But when it reaches completely down near the area of uterine artery, at that point of time, it goes below the uterine artery, or what we also call as the water under the bridge. So the water here is the urine and the bridge is the uterine artery. So it goes under the uterine artery into the tunnel of Vardheim and then comes anterior to get opened up in the trigone of the bladder. So that is how your ureter is going to come down. So while it is coming down, it is receiving blood supply from a lot of vessels. So the first vessel that it supplies is going to be, given that it is coming from the kidney, the renal artery is going to be the first artery that supplies the ureter. You see over here these branches, yes. So these are the ureteric branches. A little lower down, it gets supply from my gonadal artery, that is my ovarian artery. When it comes down further, you see that it is also getting branches from the abdominal descending aorta. So the abdominal aorta is giving it a few branches. Once it comes down even further, it is going to start getting branches from my common iliac. So this is the left common iliac and over here is the right common iliac. So it gets branches from the common iliac. Now in the pelvis, so if I want to just, I'll just note down. So when I'm talking about the blood supply, the abdominal blood supply and the pelvic blood supply is different. So in the abdomen, the first is going to be the renal artery, followed by the ovarian artery, and followed by the abdominal aorta. Whereas in the pelvis, it is going to be supplied by first the common iliac, then the internal iliac artery. The internal iliac artery itself gives a few branches. The first one is the superior vesical artery, then the inferior vesical artery, Then the uterine artery, by the way, all these vessels are supplying the ureter because it is passing next to all these vessels. And lastly, middle rectal artery. So all these arteries are going to be supplying the ureter. So it is very important that whenever you, or if at all you do end up injuring any of these vessels, it is very unlikely because most of them are major vessels. So if you still end up injuring them, that segment of the ureter is going to get necrosed, and that is of course not going to be a great thing. So this is the blood supply of my ureter, and the important parts that you need to know over here are that it lies posterior to the gonadal artery. It goes below the uterine artery and then enters a tunnel of Wartheim. That tunnel of Wartheim is situated next to the uterosacral cardinal ligament complex, and then it comes anterior to open into the bladder. This was basic anatomy and blood supply. Does anyone have any doubts whatsoever until this point? If yes, quickly tell me. I'll be waiting for 15 seconds. If you all don't have any doubts, I will be proceeding to the subsequent part. Does anyone have any doubts until now? Any doubts? Quickly tell me. None? Okay. Y'all are understanding this part over here? Please let me know. Now, why do I need to be talking about the ureter in OBGY? ब्लैडर का बात कर सकता हूँ समझ सकता हूँ बट व्हाई द यूरेटर सो व्हाट इज द सिग्निफिकेंस ऑफ यूरेटर इन OBGY very important क्यों because a lot of injuries are going to be or a lot of surgeries are going to deal with having the ureter very close to it. The most important surgery is going to be actually my commonest gynae procedure that happens to be hysterectomy. So in hysterectomy, as unfortunate as it may sound, all the locations wherein you take the clamps, those areas can be, if you're taking a clamp, if you're doing a bilateral salpingo-oophorectomy, then you're going to be clamping the infundibulopelvic ligament, which in fact includes your gonadal artery or ovarian artery. So you have to remove the ovary, so you have to detach it from its pedicle. So at the IP ligament junction, whenever you take a clamp or you ligate it, or if you just come slightly below, then if you're taking the uterine artery, then you can end up injuring it. Then it is so proximal to the uterosacral ligament that if you're taking it too close to the lateral pelvic wall, you can again injure the ureter. So uterosacral ligament. The point here is that in hysterectomy, your every single important clamp is going to be at those locations where the ureter is very close. So every single clamp, every single place where you take a clamp is going to be a potential point of injury to the ureter. So very important that in hysterectomy, you often can end up injuring the ureter. Apart from that, if I have a broad ligament fibroid, so broad ligament fibroid can be a true broad ligament fibroid or a false broad ligament fibroid. A true broad ligament fibroid is basically that fibroid which has absolutely no attachment to the lateral wall of the uterus. So it's an entirely separate entity of its own. It's something that is there on its own. It has nothing to do with the uterus. So that's the true broad ligament fibroid. Whereas a false broad ligament fibroid is more like a stage, FIGO stage 7 or grade 7, type 7, wherein there is some pedicle or there is some stalk that is connecting the fibroid to the uterus. So if I'm going to talk about the true one, I'll just draw it with red. So if this is my uterus, this is my, or these are my fallopian tubes. So if this is my uterus, a true fibroid is going to be completely situated in the broad ligament without having any connection. Whereas if it's a false broad ligament fibroid, then it is going to have a mass like this. It is going to be basically attached in some way to the uterine wall. Now, how does this make a difference? The difference is that when I talk about the ureter, this ureter in a true ligament fibroid is going to be displaced medially by the broad ligament fibroid, whereas this is going to be displaced laterally. So the ureter is going to be displaced. And because it may be difficult while removing, if I'm doing a myomectomy, if I'm enucleating this myoma and if I'm removing it, then if I do not recognize the ureter, I can end up injuring. So what do we do? Before the surgery, pre-operatively, we put DJ stents. Basically, ureteric stents are put so that when I'm operating between my index finger and my thumb, I can feel the DJ stent, and that is how I will know that this is the ureter and I cannot be going anywhere near it. So that is how it is very important in gynae surgery of myomectomy for me to know. Apart from that, if I'm going to be doing any retroperitoneal dissection, so if I'm doing any retroperitoneal dissection, which can be for any lymph node dissection or for any mass retroperitoneal, or if I'm going to have a broad ligament hematoma that has occurred. So in that scenario, I might have to go into the retroperitoneum, or if I have to ligate the internal iliac artery in case of PPH, traumatic PPH, where the bleeding is not stopping by ligating the uterine arteries. So in that scenario, I'll just switch on my AC. Sorry. Yeah. So in that scenario, I have to remember that it is very important during retroperitoneal dissection for me to be able to recognize the internal iliac and the ureters separately, and to ensure that I do not injure any other structure over here, which is the ureter. So retroperitoneal dissection for either lymph node dissection or internal iliac artery ligation or any other reason, I have to be sure about the retroperitoneal part. And lastly, during pregnancy, there is going to be physiological hydroureter because of two reasons. The first is progesterone, which leads to relaxing action, a relaxing effect on the smooth muscles of the ureter, which leads to its dilatation and accumulation of urine in it. And secondly, the gravity uterus compresses the ureter, and hence there is pooling of urine in the ureter and eventually the kidneys, which leads to physiological mild to moderate hydroureter and hydronephrosis. So very important are all these significances of ureter in obstetrics and gynecology. Does anyone have any doubt? If not, I will proceed from here. I'm assuming that there were no doubts. If any, please let me know, because now I'm going to be starting the part on injuries. Please let me know if you are understanding. I definitely love a live audience. I'm telling you all, I love a live audience, and just dulls me out if I do not have an interactive audience. So please let me know if you all are listening, and let me know in the comment section. Remember, I can only be as good as you all are as recipients of my sessions. Please respond, and I would know if you all are attentive enough. Next. So, what are the various injuries that can happen and how do I prevent them? So, the first one is going to be, of course, the hysterectomy that I've already spoken. I've already mentioned what are the potential locations where it can get injured. So, IP ligament, the uterine artery, and the uterosacral ligament ligation. The bigger question is how to prevent these injuries. So, the golden rule is, or the most important rule during cesarean section or during hysterectomy is to dissect the UV fold and push the bladder down. So whenever you dissect the UV fold, that is your visceral peritoneum, and whenever you push it downstairs, the bladder, the lower down, the bladder goes down, and the ureters behind, they also go down with it because they are going down with the trigone. This ensures that you are well away from your uterine arteries and also from your uterosacral ligaments, and it also is going to help you prevent any bladder injury. So dissecting the UV fold is a very good technique. Once you dissect the UV fold, make sure that whenever you're taking the uterine artery clamp, it has to be immediately ligation. Uterine artery ligation has to be immediate lateral to the cervix. So the cervix that is there, you have to immediately ligate it lateral to it and not go too far away from the cervix, because the more you go towards the lateral pelvic wall, the chances of injuring the ureter are very important. So first of all, dissect the UV fold and then take the uterine arteries. Do not do it without dissecting the UV fold. And lastly, pull the uterus or give traction to the uterus vertically upwards. So basically, when you pull the uterus vertically upwards, similarly, the bladder is going to get pushed down, and hence the ureter is also going to stay down. And it is going to be much easier for you to apply clamps. So the first thing that we do whenever we are doing an abdominal hysterectomy, an open abdominal hysterectomy, is that we put two straight clamps. Those straight clamps, they are very important because they help me in grasping the uterus and also to pull it upwards for it to be easier for me to be able to operate inside the pelvis. So very important that I do these things, and these things are going to significantly reduce the risk of ureteric injury. The next is during TLH, that is during laparoscopy, energy sources. Energy sources can be any monopolar cautery, bipolar cautery, harmonic scalpel, several energy sources. So, energy sources related injury, and this is very dangerous. The reason being, imagine that this is a cautery and this is a ureter. You touch this cautery to the ureter and you forget it. You don't get to realize that you have just touched it. Now, the thing is, you have only had a point that you have touched. But the unfortunate part is, every cautery or every energy source has some bit of lateral spread. What is lateral spread? Even though I'm touching it here, there is going to be a burning effect or a cauterization effect on the surrounding small bit of area as well. Now, what this leads to is, मुझे जब वो injury हुई है, it is going to be a small dot. But eventually, because of this lateral thermal spread, we call it the lateral thermal spread or the thermal spread, the surrounding blood vessels, I have told you it is so richly vascular. Those small capillaries, those small arterioles are going to get cauterized. And when that happens, gradually there is going to be ischemic necrosis, and that ischemic necrosis is going to result in a hole inside the ureter. Basically, a proper injury is going to occur to the ureter. The same thing applies also to the bowel loops. So you have to make sure that you are very careful whenever you're using any energy source during laparoscopic hysterectomy. So important that you know about lateral thermal spread. Next, whenever I'm doing any ovarian surgery, the ovarian surgery mostly is if I'm doing an oophorectomy or a cystectomy. And cystectomy also not that common, but whenever I'm doing an oophorectomy and I have to take a clamp on the infundibulopelvic ligament, because that is the ligament that brings the gonadal artery or the ovarian artery to the ovary. So to be able to remove the ovary, I have to like it. The artery, its blood supply that is coming directly from the aorta. So during ovarian surgeries, I have to be very careful whenever I am operating on the ovary. Apart from that, if I'm doing a vaginal hysterectomy, then in that the ureter might be kinked. So kinking basically is because the uterus is completely prolapsing out. Along with it, it also brings the bladder down, which is also called as the cystocele. Now, when the cystocele or the bladder is coming out from the anterior vaginal wall, the ureter also tend to come down with it. And if I'm not doing a good enough um, sorry, good enough bladder dissection, then it can so happen that even the ureter has been taken up in one of the clamps and it has gotten injured. So make sure that you are properly dissecting the bladder. In fact, one of my teachers at KEM, Dr. Kimaya Mai, a brilliant, a beautiful surgeon in gynecology, a brilliant vaginal surgeon, I would say. She would always tell me that the most important person in a team who's doing vaginal hysterectomy is that assistant who holds the bladder. There is no more important thing to do in a vaginal hysterectomy than securing the bladder with a Landon's retractor or a right angle retractor. A very important role that that assistant plays, because doing VH is very easy. पट तीन clamps लगा दो 15-20 मिनट में हो भी जाता है वो बहुत लोग का. But if the bladder is loose, or if you let the bladder come in, if you have not retracted the bladder well enough, you have not dissected it well enough, it can be very difficult to identify that injury there itself and to repair it as well, because the vaginal orifice is very small. So that is what she used to say, remember that. And of course, other surgery that I've mentioned is broad ligament myomectomy. So whenever I'm talking about any injuries, just a moment. So broad ligament myomectomy. So these are all the important surgeries that can lead to injuries to the ureter. Now, how do we diagnose them? Very important, how to diagnose. So there are two ways of diagnosing. The best way is, of course, if I'm diagnosing it during the surgery. So if I'm diagnosing it during the surgery, excellent, further damage is prevented. But unfortunately, a lot of people don't realize that, and they get to know post-operatively, especially in thermal lateral spread injuries. you get to know during surgery, post-op recognition or post-op diagnosis. So unfortunately, post-op period में ही maximum लोग को पता चलता है, and especially in thermal spread, it takes time for that ischemic necrosis to occur, and hence it is a very classic post-operative complication that you realize that there's a urinoma that is occurring. So how do we diagnose them? So talking about the during surgery part, one thing that you have to remember is appreciating either by visual inspection or by palpation, appreciating peristalsis of the ureter is not sufficient to be able to diagnose an injury to the ureter. So बहुत लोग क्या करते हैं, वो लोग इंजुरी हुआ है, डाउट है उनको, वो लोग जाके यूरेटर को फील करते हैं, फिर यूरेटर को देखते हैं 10 मिनट और देखते हैं कि उसमें पेरिस्टालसिस आ रहा है कि नहीं। अरे भाई, पेरिस्टालसिस तो वैसे भी आएगा, तुम लोग नीचे का सेगमेंट काटो तो भी पेरिस्टालसिस आएगा। इनफैक्ट द यूरिन इज नाउ going to come through the peristalsis, because of the peristalsis, and it's going to form a urinoma in the retroperitoneum. So do not think that if you're seeing the peristalsis, then the ureter is intact. That is never going to be the case. So that is the first golden rule that you have to follow. Apart from that, if I am having any doubt, then I can inject one of the two drugs, the safest one being indigo carmine. A few people even give methylene blue. So indigo carmine is to be given by IV, and then I have to look for extravasation, green color extravasation in the retroperitoneum or in the area where I'm suspecting the injury. So indigo carmine IV से देना है, IV से of course वो blood में जाएगा, blood heart में जाएगा, heart से pump होके kidney में आएगा, and kidney के through the ureter it is going to come out. So that's a very important way of recognizing it. Or the other way to do it is post-operatively, I can do cystoscopy. Cystoscopy is basically endoscopy of the bladder. So from the urethra, I'll be inserting a small camera inside the bladder, and I'll be seeing both the ureteric orifices. So both the orifices are seen, and I have to see whether there is efflux of dye that I've given through intravenous route. सो ये मैं जो आईवी से इंडिगो कार्मिन या मिथिलिन ब्लू दे रहा हूँ, यहाँ पे मिथिलिन ब्लू भी देख देता हूँ। आई हैव टू सी वेदर इट इज कमिंग फ्रॉम, अगर ये मेरा ट्राइगोन है और ये मेरे दो यहाँ के यूरेटर के ओपनिंग्स है, यहाँ पे मेरा यूरेथ्रा है जो नीचे जाएगा, सो आई हैव टू सी वेदर द डाई इज बीइंग seen to come out from both the holes via cystoscopy. If it is coming out through both the holes, it is obviously going to confirm that both your ureters are most likely to be intact and there has been no problem, there has been no issue that has occurred to the ureters. So, cystoscopy post-operatively, very important. This was intraoperatively. Once you diagnose it intraoperatively, how to repair it, I will tell you, the repairing part will come together. But the most important part here is post-op recognition. So post-op diagnosis is very troublesome because the complaints often are something like fever, malaise, leukocytosis. Your WBC counts are going to increase significantly because that probably may be leading to an infection. Apart from that, you're going to have renal angle pain. So the patient is going to give you that renal angle pain. Not so much. Renal angle pain is very classical of pyelonephritis, but the area, the back area, you're going to get some bit of pain. You may say reduced urine output. Okay, but remember that your one ureter is still intact. I mean, it has to take a Herculean effort to damage both the ureters in the single surgery. You have to be one of the most terrible surgeons that has entered the OT to damage both the ureters in a single go, unless there were dense adhesions and all. But apart from that, it is very unlikely that reduced urine output is going to be the complaint because the other ureter is still doing its work and that is still adequate enough to compensate for the entire day's urine. So very important for you to note that. And apart from that, then if you do a USG, you might see an abdominal or retroperitoneal collection. That imaging study can be a USG, it can be a CT scan. And if you aspirate that fluid by or under ultrasound or CT or ultrasound guidance. And if you do the serum creatinine of that fluid, if it is more than the serum creat, then it is confirmed that it is urine. Remember that the serum creatinine is a byproduct of your muscle metabolism and it is supposed to be excreted from your body. So your urine content has has creatinine of almost 10 units. So basically the same mg per dl, not units, the same creatinine in your serum, the normal levels were between zero point 0.8 to 1.2. In the urine, the normal levels are going to be between 8 to 10. So if you see any value that is not just more than, but anything more than 2x, twice of serum creatinine levels, then it is more or less confirmed that it's a urine collection, or what we also call as urinoma. Urinoma is a collection, an encysted collection which contains urine inside it. How do I confirm this diagnosis? How do I know where the injury is? So, how to diagnose? Before I go on to the diagnosis and the surgeries, has everyone understood everything until here? Please quickly tell me. If yes, I will proceed. Does anyone have any doubts? Also, our test series for FET, which is there in the month of March, and PDCET, which is there in the month of February, which is there in the month of April, sorry. The test series are out on our app. They are being added every other day. So we are making a test series of around 10 to 20 tests. We already have a question bank to add to it. We have a test series which is going to exactly mimic the timing and everything of the actual exam. The total number of questions, the paper pattern is exactly like your actual exam. So do attempt them and get your scores. Apart from that, also Dr. Prathamesh and Dr. Gaurang, two of our students, have cleared their MS exams, and Dr. Gaurang has to even achieve distinction in all the subjects. So congratulations. So our MS results have come out and they are very good results. I'm very proud of these students. So anyway, continuing. Does anyone have any doubts? If not, I will continue. So how do I diagnose it? Definitely, and how do I know where is the problem? So the first thing that I do is going to be a CT urogram. In CT urogram, basically they not just do a CT, but they also inject a dye IV. And on CT urogram, they take or they do delayed acquisition. So basically, थोड़ा delay करके लेते हैं so that they can watch every single frame of the dye coming out, and then you will see from where the dye is leaking. The other option, and what a few people do say, is to do a retrograde pyelogram or a retrograde RGU or RGP, retrograde pyelogram cystogram, whatever. Remember that whenever you inject a dye retrograde into the bladder, at the trigone, at your uretero-vesical junction, there is a valve. Your valve is going to prevent any dye from going from the bladder to the ureter. The valve is only going to let fluid or urine or dye to come from the ureter to the bladder, but the other way around it is not possible, which is why to do a retrograde gram is only indicated if you're suspecting a bladder injury as well. If there's a urinoma, you're not sure whether the bladder is the issue or the ureter is the issue, in that case you do it. But remember, your retrograde pyelogram or a retrograde cystogram is literally and only a thing for your bladder to know whether there is any loss of integrity in the bladder wall. So very important for you to know that it is not that useful in investigation if you are suspecting ureteric injury. Apart from that, in the exams, you might be asked, is there any classical way of knowing injuries or chronic complications? Then the question or the answer that they are expecting from you is answer on how to diagnose fistula, because fistula is a long term thing that develops 2 to 4 months or maybe even 6, 7 months after the procedure has been done, because an epithelial tract has to form between the two injured organs. So whenever there is a fistula, it can be a uretero-vaginal fistula, it can be a vesico-vaginal fistula, it can be a urethro-vaginal fistula. How do you know? So what we do is the classic 3 swab test. ये 3 swab test क्या है? Now मैं sagittal view में बताऊंगा. If this blue color is my bladder with both my ureteric junctions over here, and posterior to that is my ये filled bladder है, by the way. Posterior to that is my vagina. Of course, I'm not drawing the uterus above that. So there can be fistulas that can be formed between the, I will just make a ureter also over here. So there can be fistulas that are formed between the ureter and the vagina, between the vagina and the bladder, or between the urethra and the vagina. So what we do is we take three gauze pieces. अभी gauze piece को कौन से color से बनाऊं? Ideally it is white. I will use a grey shade. We keep three gauze pieces. The first one gauze is kept over here. The second is kept over here. And the third one is kept over here. So these are the three gauze pieces that I have seen that I have put there, or three swabs, 1, 2, and 3. What I do then is I inject methylene blue back into the bladder. So methylene blue is injected into the bladder, and of course the Foley is kept in situ and is clamped so that the methylene blue doesn't come out. So if your first swab is getting blue, बेसिकली अगर ये पूरा ब्लू हो रहा है, देन इट इंडिकेट्स कि यहाँ पे आपका कनेक्शन बन चुका है. सो ये जो कनेक्शन बना है इन दोनों के बीच में, दैट इज गोइंग टू बी इंडिकेटिव ऑफ अ vesical vaginal fistula. So first swab, if wet plus blue, then it is going to be indicative of vesical vaginal fistula. Again, remember, ये methylene blue cannot go into the ureter because of the presence of valves that are present at the uretero-vesical junction. So no fluid from the bladder can go into the ureter, which is in fact a good thing, which reduces the risk of pyelonephritis. So whenever the bladder is full, and let us assume that your bladder, because of old age or something, has a UTI. Now, if that UTI goes up through the ureter, it can go and ascend up to the kidneys and can lead to pyelonephritis. I do not want that, which is why those valves are very important. So if there is a ureteric injury, it won't show. Whereas if the first swab is wet but not blue, so it indicates that गीला तो हो गया लेकिन नीला नहीं हुआ है, then it indicates that the bladder is okay but there is some other source that it is coming from. So यहाँ पे मैं question सोचूंगा, is it uretero vaginal fistula? Now, how do I confirm it? I already know that to check ureteric fistulas or ureteric injuries, I have been doing city pyelogram. So instead of doing a city pyelogram or a city urogram, I will give the patient a drug. Now, I want you all to answer me in the comment section. What is the name of that drug? I'm just giving you 5 seconds. Quickly type. What is the name of the drug that I give orally? It's a tablet that I give orally that helps me in the diagnosis of a very classical test, by the way. This अभी CT scan ये सब आने के ऐसे उसका जरूरत नहीं पड़ता है. But yeah, tell me, what is the name of that drug? The name of the drug is phenopyrazine. जो phenopyrazine है, pyrazine, this lends the urine a yellow color. So when you give it, and now if the first swab gets yellow, then it is going to tell me that the problem is between the ureter and the vaginal wall, and hence it is going to be a confirmed case of ureterovaginal fistula. The other possibilities in this test, if the second swab is wet and blue, then it is a urethro, not a uretero, ureterovaginal fistula. And lastly, if it's the third swab which is getting wet again and again, blue and wet, then it's a case of SUI. बेसिकली पेशेंट को मैं कफ करने बोल रहा हूँ और उसका यूरिन लीक हो रहा है, एसयूआई या फिर यूरिनरी इनकॉन्टिनेंस का केस है, इसलिए सबसे नीचे वाला स्वॉब स्टेन हो रहा है. अगेन इन यूरेथ्रोवाजिनल फिस्टुला इट इज पॉसिबल, बट मोर लाइकली दैट इट इज बिकॉज ऑफ द एसयूआई और बिकॉज ऑफ फॉल्टी टेक्निक, कि एकदम घटिया तरीके से तुमने अंदर मिथिलिन ब्लू डाल दिया, यू डिडंट close the bladder well enough by the Foley's bulb, and now all that methylene blue is leaking out from the bladder through the urethra. सो फॉल्टी टेक्निक की वजह से भी, या फिर डालने से पहले ही तुम लोग ने स्वॉब्स डाल के रखे हैं मिथिलिन ब्लू डालने से ही पहले, एंड मिथिलिन ब्लू डालने के बाद पता चला कि डालते वक्त ही थोड़ा नीला पड़ गया बाहर का एरिया, so a faulty technique again can attribute to the third swab getting stained. But these are the four possibilities of the three swab test. Very important for you to know this part. With this, does anyone have any doubts? Because इसके बाद में सबसे important part chapter के आने वाला है, that is going to be the surgeries. Does anyone have any doubts whatsoever? Quickly tell me. If not, I will proceed. I'll be waiting for 15 seconds. If not, quickly tell me. I will proceed. Any doubts whatsoever? No? Okay. Chalo. So now, how do I repair these injuries of the ureter? But before talking about the how to repair, कुछ MCQ जैसे questions का अपन आंसर करेंगे. So the first question is, what is the most common site? So the most common site is going to be the pelvic ureter, because मेरा सब pelvic surgeries ही है, hysterectomy जिसमें injury हो सकता है. What is the most common surgery? Of course, it is total abdominal hysterectomy, laparotomy से किया हुआ. Next, it is going to be, what is the most common injury, or how is it formed? So it is mostly because of suture that was taken, which has led to a stricture as well, a chronic stricture. So ये suture की वजह से block हो गया था, obstruction हो गया था to the ureter. What is the most common activity? So most common activity that leads to this is attempting hemostasis. यूट्रन आर्टरी छूट गया, हिस्टेक्टमी में ब्लीड हो रहा है, ब्लाइंडली तुम लोग सूचर ले रहे हो. रिमेंबर, डॉक्टर बेली हैज सेड, वही बेली बाबा अपना फाइनल ईयर सर्जरी के बुक वाला, फाइनल ईयर एमबीबीएस का, बेली एंड लव वाला. मोर देन bleeding, the attempt to stop bleeding is more dangerous. So basically bleeding से उतना दिक्कत नहीं आता है, बट जो हम attempts करते हैं to stop the bleeding, inadequate attempts, उससे ज्यादा injury, उससे ज्यादा नुकसान होता है. This is what they have said. So it is not the bleeding, but the attempts to secure the bleeding that leads to more dangerous problems or injuries. So it's a very important line that they have said. I have put it out in a very wrong way. उसका एक्चुअल लाइन बहुत ही ऐसा एस्थेटिक है, मैंने बहुत वाट लगा है, माफ करो मेरे को बेली भाई, माफ करो. सो मोस्ट कॉमन लॉन्ग टर्म एनी इम्प्लीकेशन, नॉट रियली. लॉन्ग टर्म इम्प्लीकेशन में सिर्फ ये है कि एक साइड का यूरेटर उड़ गया, उधर का किडनी का क्या होगा. सो दैट इज वन थिंग, बट स्टिल इट डजंट रियली लीड टू मच. So most often the ureteric injuries don't lead to anything in the longer term because it is diagnosed very quickly. You will repair it or do something about it. वो नौबत ही नहीं आएगी कि long term कुछ complication बैठा उसको. So whenever I talk about repairing, the injury, I have to split the bladder into, or the ureter into, three segments. So major injuries का जब मैं बात करता हूँ, तब मैं ureter को three segments में divide करता हूँ. The three segments are of course on the distance from the kidneys. So there's a proximal 1/3, there's a middle 1/3, or I will just say the middle, and there is a distal. So the proximal is basically from the renal pelvis to 5 centimeters distal to it. Whereas mid is 5 centimeters distal से लेके, distal to the kidneys of course, till the pelvic brine. And lastly, जो distal है, that is from pelvic brim to the bladder insertion. So these are the three places or the three sites that we have just roughly determined, on the basis of which we'll be doing all the surgeries. So proximal 1/3, middle 1/3, and the distal one third. The surgeries are going to depend on where the injury is. So now, सबसे पहले मैं बात करना चाहूंगा what if there is a just a small transaction कि तुमने कुछ तो सर्जरी करा तो एक छोटा सा निक लग गया. So for minor surgeries, remember if there is any minor nicking, then you don't need to do much. So for minor transaction or minor injuries, you do a primary repair. Basically उधर ही suture ले लो with small absorbable sutures that are 4-0 or 40 or 50 absorbable sutures. So छोटा सा अगर निक गया है तो बस इतना ले लो. But what if there is a bigger injury? So if there is a bigger injury in the proximal or the middle one third, then in that scenario, the surgery that we do is going to be a ureterostomy. So for proximal and middle one third, the procedure name is going to be called as a ureterostomy. Stomy मतलब क्या? होल बनाना. How do we do it? So I'll put up a picture for you all. I have put up many pictures today. I've gotten many pictures today. So यहाँ पे हम क्या करते हैं? There is a process called as spatulation. So ये spatulation क्या process है वो मैं तुम लोग को अभी दिखाना चाहूंगा. Very important and very nicely done. मैंने 2-4 images लिए हुए हैं. Just give me a second. मैं पता कर लूंगा वो images कहाँ पे है spatulation वाले. Just give me a second. Yeah, मिल गया. So यहाँ पे मैंने 3 चीजें दिखाई है. So सबसे पहले ये जो लिखा हुआ है यहाँ पे इसको देखना है आप लोग को. जो तीसरा वाला है उसको अपन एंड में देखेंगे. So over here you see what I have done. So imagine ये मेरा सेगमेंट था, ऐसा कट गया है दोनों. ये कटने के वजह से और डीवाइटलाइज हो गया है. सो मैं सबसे पहले जो डीवाइटलाइज टिश्यू था, अगर ये यहाँ पे ऐसा नेक्रोस टिश्यू था क्योंकि कट गया है तो ब्लड सप्लाई विल बी ब्रोकन ऑफ. So I will cut it off completely. So basically I will resect the devitalized segment. Once the devitalized segment is resected, I will do this spatulation for 1 centimeter. So ये जो distance है ये 1 centimeter है. Spatulation is nothing but just creating a V cut. So अगर ऐसा है मेरा ये, तो मैं एक ऐसा यहाँ पे ऐसा वी कट बनाऊंगा. बेसिकली ऐसा एक वी कट बनाऊंगा. अगर ये मेरा ये था तो एक वी कट बनाऊंगा. उससे क्या होता है, ये मेरा थोड़ा ओपन अप हो जाता है. A similar V cut is going to be made on the distal ureter का टूटा हुआ टुकड़ा. So basically मैंने यहाँ पे एक V बनाया है, देखिए you can see, whereas एक यहाँ पे भी on the back side एक V बना हुआ है. This is made and then these two edges are put together. This is also called as, यहाँ पे भी तुम लोग देख सकते हो, ये devitalized tissue था. ये devitalized tissue को हमने काट दिया यहाँ से, and वो काटने के बाद में हमने एक यहाँ पे ऐसा V बनाया है और एक यहाँ पे V बनाया है, and then we have sutured them together. What this does it, you can see ये थोड़ा सा broad हो गया है बीच में. This broad area is then sutured, and after suturing it ensures that this broad area, when it will come closer because of the obvious fibrosis that takes place after the surgery, it will prevent a stricture. That stricture is very important because if that stricture keeps worsening, then gradually, because of back pressure changes, the kidney can literally get damaged and you'd end up with one kidney losing its complete function and the other kidney being the sole functioning kidney. So that stricture is very important to be prevented, and hence the spatulation ensures that that area of suturing is a broader one, and hence after it heals because of fibrosis there is no stricture formation, and hence directly suture नहीं लेना है. ये प्रोसेस को हम कहते हैं spatulation. Spatulation is nothing but creating a V-shaped incision along the edge of 1 centimeter. So this area is 1 centimeter का बनाने का, आगे और पीछे opposite sides पे. And once this is done, obviously to maintain the flow, I have put in a DJ stand. You see this DJ stent ऐसा आता है, double S stent भी बोलते हैं इसको. This DJ stent has been put, and also there is a drain that is put in the retroperitoneum, so that if this anastomosis leaks, then you can end up re-exploring and re-repairing that part. I have seen one case ऐसा जहाँ पे re-repair has been done. So you see यहाँ पे we have inserted a corrugated drain. That corrugated drain is basically going to drain that peritoneum, that retroperitoneal area, and is going to tell me if there is any leakage of urine that is happening. Now this is good, this is well and good if this was my ureter, the first part, and this was my ureter, the second part. What if instead I had a ureter, the proximal part here, and the distal part is so far? I'm not able to bring them close. In the upper and middle segment, what do I do? What I can do is I can deviate this onto the other kidney's ureter. So the other kidney that was there, the ureter that was coming out from it, I will divert this ureter and I will put this ureter on this one. This is called as ureterostomy. So same, it's a ureterostomy, but यहाँ पे you are changing the direction of that ureter to the other side's ureter, and this part you will be suturing off and closing it off because it is a useless part, and hence now both the kidneys are going to drain only in one kidney. So basically this ureter is going to support two kidneys. Over here you can see a picture, you have a picture of ureterostomy, when here we have done some spatulation. You see the spatulation has been done over here. The spatulation you can see over here, it has been done. And then on this other straight ureter, a stoma has been created. That stoma and this area is stuck together, and the final outcome is going to be like this. Both the kidneys draining into one single ureter. And this was the ureterostomy for upper one third or middle one third injuries. Did you all understand this point? Does anyone have any doubt? Of course, the DJ stent, we in our institution used to keep it for 6 weeks. A few people remove it after 1 or 2 weeks. It is all up to them. People even remove the pulleys after a week or two after this procedure. We personally prefer to keep it a little longer. Did everyone understand this part? Does anyone have absolutely any doubt in what to do if there is an upper segment or a middle segment injury? Very simple, ureterostomy. Stomy is creating a fake hole in it. And this is ureterostomy. Trans is shifting one side's ureter to the other side. Okay, no doubts. Now moving on to the other surgery. And if I'm going to talk about the other surgery, then before going there, I have to ask you if you all have any doubts whatsoever. No doubts? Okay. Now this was for the proximal part. What if there is a bigger damage that has been done? And when I say a bigger damage that has been done, I intend to say what if, I'm just putting up another picture. If the damage has been sustained in the distal part. Now when I talk about the distal part, what do I exactly mean? So if this was my bladder and if this was my ureter that was draining inside it, if there has been an injury wherein there is small ureter that is remaining over here and the other one is over here. Now, because this has completely lost its blood supply because of that transaction, I have to somehow bring it over here. This still is doable. I am still able to pull the ureter by freeing it from its retroperitoneal attachments. So once it comes down slightly, what I'm going to do is I have two ways. I can either repair it extravasically, that is from outside the bladder, or intravasically. Obviously, if I have to repair from inside the bladder, I will have to open this bladder up, and hence an abdominal incision is going to be required for intravesical, whereas for extravesical, you wouldn't require a complete opening up of the bladder. So over here, now you can see the external neo or uretero-neocystostomy. So uretero-neocystostomy. So what does this mean? Uretero is ureter, neo is new, Cysto is bladder, stomy is hole. So basically, you are creating a new hole apart from the original trigone into the bladder. So what do you do is, the first thing is on the serosa of the bladder and the mucosa ko chhodna hai, the muscular layer, the detrusor, you take this elliptical incision. Once this elliptical incision is taken, again you create a spatula over here. You see this spatula has been created. This spatula is basically helping this become a broad thing. This ureter becomes much more broader. Now, one side of it is sutured here, you can see. Now, before you suture the other end, this mucosa, you can see the mucosa over here. The mucosa, which will also contain the transition epithelium, is still not opened. Now, after this, you will open it up and you will send a stent, a ureteric stent. It can be a DG stent, it can be any stent. This stent is going to be sent from downwards. It can be sent up cystoscopically, or you can just send it up and then you can attach it over here. It is going to be sent. This stent is going to be passed from inside this ureter so as to ensure that the continuity is maintained. And finally, the overlapping area, this overlapping area that was there of the bladder, of the serosa, is pulled over this, and the ureter has now been implanted. So basically, I have created a new hole in the bladder to implant the ureter in that location, because the earlier location was must have necrosed out because of the injury. The same thing can be done intravesically as well. Intravesically means I can even do the same thing from inside. So for that, I have to first open the bladder. I have to literally open the bladder, and then through another incision, I have to pull this ureter inside. Once it is pulled, I will do spatulation and suturing. This technique is called as polytunnel lead better intravesical technique for ureteroneocystostomy. So nothing, basically I open the bladder, I look at one spot, I create a hole there, then I pull the ureter in, then I spatulate it, and inside I will invert the edges and suture it. So this is also called as the intravesical technique of ureteroneocystostomy. Very important for distal injuries. Does anyone have any doubts whatsoever? Any doubts? Last two surgeries are remaining, not that big. Please quickly tell me. If not, then I will just go through those two surgeries and then we are done with the session. No doubts. If there are any doubts, I am answering in the comment section of our YouTube channel. I'm just making sure that we have the right picture that I'm putting out and not some random wrong picture. Okay. Now, all these distal surgeries were for the part wherein I can still pull the ureter and I can insert it onto the bladder. The neocystostomy was only possible if the ureter could reach. Now, over here, you see that this ureter has been detached, and this detachment has literally created a big distance between them. Because there's a big distance, now I have to attach them. What do? I cannot just pull the ureter, because the ureter is not getting pulled anymore any further. And if I pull it even more, it will lead to more further damage to the ureter. So now what I have to do is I cannot pull the ureter, but I can push the bladder to that direction. So how do I do that? So I take an oblique incision, and on the oblique incision, I will start putting up a small incision perpendicular to it. After that, this incision is pulled in opposite directions. Once it is pulled in the opposite direction, what will happen is this will come closer to this area. So basically, this was the incision. Because I started pulling it at 90 degrees, it became like this. And now I have this area that is closed and I have an increased length over here. So by doing this, I pulled the bladder over here and these two edges came together, which I sutured. Now this bladder I have pulled over here, it has to stay there or else it will end up retracting back. For that, I have to take a stitch on the psoas muscle, or on the psoas tendon is a better word. which is also called as a psoas hitch. Hitch is अटका रहा हूं मैं, हुक पे डाल रहा हूं वैसे. So the psoas hitch is a very important step. It is taken with a non-absorbable suture, and you have to avoid taking this suture through the mucosa of the bladder, because that will eventually otherwise lead to, first of all, a fistula, and secondly, bladder stones can be formed because you are using a non-absorbable suture. So a non-absorbable suture has to be used to take a hitch. Basically, I'm attaching this extra pulled point onto the psoas muscle so that it doesn't go back to its original step or to its original location, because of course the bladder is going to contain detrusor, and once the detrusor contracts it will pull it back. So to prevent that, I have to ensure that it is getting pulled down. So very important for me to remember this step. Another thing that I have to remember is whenever I do all these surgeries, especially the neocystostomy, wherein I am putting the ureter onto the bladder, never put that on the dome of the bladder over here. When you're putting that thing, never put it onto this new ureter जो है, never put it directly onto the dome. उसके बाजू में ही डालना है. Why? Why is this wrong? Because when the bladder fills up with urine, this dome placed ureter would have gotten kinked, and that would obstruct the urine flow, and hence you have to put it laterally, just lateral to the trigone or in the surrounding areas. Now you tried doing this and you still felt that the bladder part that you were pulling was still not enough because the resector segment was way too long. Now I have only one thing that is left. I mean, actually two, but still, regarding the bladder, there is one surgery left, and that is called as a Bowari's flap. Where you see a Bowari flap. What's a Bowari flap? So what I have done over here is, in this Bowari flap, basically on the bladder, now you see that there is such a large resected segment. So on this bladder, I have taken this incision. This incision is taken and a flap is raised. This flap, by the way, has to be more than 2 to 3 centimeter for it to be viable. Then I will attach it, after spatulation, of course, this ureter to this flap. And then I will suture this flap up completely. And then suturing, basically, I have created an extension of the bladder. Even this can be put on a psoas hitch to ensure that it stays there. This is called as a Bowari flap repair. तो बेसिकली एक फ्लैप को मैंने ऐसा, ये था उसमें से ऐसा दो मैंने ऊपर उठाया, मैंने ऐसे लिटरली ब्लैडर में से दो उठाया, एक फ्लैप उठाया ऊपर, एंटायर मस्कुलर म्यूकोसा ऑल लेयर्स टेकन विद इट, एंड देन वहां पे मैंने उसको यूरेटर सिला दिया एंड आई पुट इट बैक एंड आई सूचर्ड इट. दिस वाज द बोआरी फ्लैप. Again, this is limited by how much of a flap can I create from the bladder. What if this flap is also inadequate and I'm unable to still make sure that the ureter is completely reaching the bladder, and it is not even reaching the other side's ureter for me to do trans ureterostomy. So now I have only one surgery that is remaining, and that surgery's name is going to be called as ureteral ileal interpositioning. So basically, what I do over here is, if let us assume this was my ileum and this was the mesentery that was supplying it. The mesentery that was supplying it. This mesentery, of course, contained some blood vessels as well to ensure that the blood supply is there. So what I did was, I resected this segment completely. So now I was left with two such segments. So ये दोनों को मैंने जोड़ दिया bowel loops को, and apart from that I also had a loop of the bowel, or of the ileum to be more precise, with the mesentery intact on it. तो ये मेरे पास ऐसा आ गया. Now what I did was, I took this and I put the ureter on one of its sides. So जो ureter था वो मैंने इसको by the way suture कर दिया पूरी तरह से. तो ureter को मैंने उसके एक साइड पे डाल दिया और ये दूसरे साइड पे मैंने bladder पे उसको suture कर दिया. Now what are the problems that can arise? The first thing is, the bladder is not going to be that conducive to the presence of the contents of my ileum. And the most important is going to be E. coli, which is a commensal there. And secondly, the mucus production that occurs by the bowel loops, by the columnar endothelium, epithelium that is present. So the urine is going to consistently have mucus in it, which is going to be a very troublesome experience for that lady. But if the ureter has been transected so high up that it is not even reaching the other kidney, that it is not even ready for a Boari flap, then this is the only surgery that is going to be left. To ensure, by the way, ileum है तो बहुत सारे nutrients absorb होते हैं, so we have to make sure that we take a segment that is 10 to 15 centimeters away from the ileocecal junction, because at ileocecal junction के 10-15 सेंटीमीटर proximal वाला area is the one जहां से maximum nutrients are absorbed. So to prevent malabsorption, I have to take a segment that is 10 to 15 centimeters away from the ileocecal segment. And this was ileal interposition. Very rarely done. You will hardly find it being done. But yes, this is how we are going to be doing it. You see that यहाँ पे वो जो flap है वो उन्होंने maintain किया हुआ है. The flap is maintained and you can see that the blood vessels are also supplying. So even this loop of ileum is intact and is not getting necrosed out. And that is all when I talk about surgeries for ureter. Does anyone have any doubts whatsoever with regards to anything that I have spoken today? If not, I will end this session. I hope you all learned from this. Tealint, very important, very good. Just read Tealint, that is good enough at your level. Excellent दिया है वहाँ पे. मन रहेगा और पढ़ने का तो जाओ पढ़ो कैम्पबेल, बट आई वुडंट रेकमेंड. बेरेक नोवैक में ज्यादा नहीं दिया है, बेरेक नोवैक में ज्यादा इनकॉन्टिनेंस पे दिया है. So, and of course, after all these repairs of bladder, I have to fill the bladder. I have to check whether the sutures are watertight or not to ensure that there is no leakage of urine. But yes, I guess nobody has a doubt. I hope you all understood this session and I hope these free sessions are helping you all. Do subscribe to Conceptual. Now, by the way, we have around 25 case presentation sessions that have been done with Dr. JB Sharma sir that are live exclusively for our subscribers on our application. We have covered every single topic. Small topics like puerperal sepsis, उस पे भी case presentation है, so do attend them. They are available on the app. Apart from the PD, CET, and FET test series and question bank. So do keep watching Conceptual. If you have any doubts, keep asking in the comments. I will keep answering them every day. This is Dr. Aditya signing off. Thank you so much.
ये वो वाला ना जो नीट पीजी का है हमारा, एफ